Greetings from India, and thank you, organizers, for calling me from India. Thank you so much. A lot has been spoken about the scapular dyskinesis. Yes, the scapula is important, but how to correct it? That's my topic for today. We all talk about the muscles surrounding the scapula, and I would like to take you back to the works of Leonardo da Vinci depicting the importance of the scapular and the shoulder muscles. So let's embrace the clinical challenge of shoulders complexity. The shoulder provides extraordinarily wide range of functional versatility to the upper limb. Such versatility is apparent while considering the large amplitude of movement, like reaching or touching your hand towards the back. As physical therapists, we marvel at the complexity, strength, and agility of the movements performed by the healthy shoulder. At the same time, however, we are called upon to treat larger number of patients with shoulder pain and dysfunction. As reflected by the enormous volume of published literature devoted to the topic, the evaluation and treatment of shoulder pain or dysfunction represents a both source of excitement and challenge. What is scapulohumeral rhythm? Back to basics. Why scapula is important? For every 2 degrees of glenohumeral movement, there is 1 degree of scapulothoracic movement. And that is why for that 1 degree of scapulothoracic movement, we are interested in knowing why the scapula is important. What is the agony of the shoulder? Humeral head migration generally decreases the subacromial space, and scapular reorientation generally increases the space across scenarios. This strongly implies that the superior humeral migration is a dominant fatigue-related mechanism associated with increasing the likelihood of impingement. What is scapular dyskinesia? It is shoulder's nightmare. We know that the scapular dyskinesis is nothing but an altered scapular motion and position have been termed as scapular dyskinesis. The definition of dyskinesis is an alteration of normal scapular kinematics. Dyskinesis is a general term that reflects the loss of normal control of motion. As physiotherapists, we always talk about movements. I think you have sat enough and it's time to slightly get up for a few seconds, and I'll teach you what is the normal scapular kinematics. Can everybody get up slightly? For a few seconds. Just keep your hand like this. Just keep your hand like this, okay? This is upward rotation of the scapula. This is downward rotation of the scapula. This is upward rotation of the scapula. This is downward rotation of the scapula. This is internal rotation of the scapula. This is external rotation of the scapula. This is anterior tilt of the scapula. This is posterior tilt of the scapula. The orientation of the scapula is more in the scaption plane. And that is why we cannot say that the scapula is like this. It's 30 to 40 degree anterior to the coronal plane, 10 to 20 degrees. Please sit down, please sit down. It's 10 to 10 degrees anterior tilted, 10 degrees upward rotation, and 30 to 40 degrees anterior to the coronal plane. And that's very important. And that is what we need to see and observe when we talk about the movements of the scapula. This is what I taught you about the 3-dimensional kinematics of the scapula, which all the Scapula Summit people have learned. Dyskinesis have been hypothesized to relate to changes in glenohumeral angulation. So it's not about the scapula. It can be a glenohumeral internal rotation, AC joint strain, subacromial dimension problems, shoulder muscle activation problems, or humeral position and motion. What are the potential biomechanical mechanisms which are contributing to the alteration of the scapula? There are many. Pain is one of the important factors. Soft tissue tightness is one of the important factors. Muscle activation and strength issues, imbalances related to the strength issues, muscle fatigue, and thoracic posture. Slouch and then move your shoulder. You can't, okay? It's as simple as that. What are the enigmatic force couples? We know that the serratus anterior and the lower trapezius are the important muscles, which are the important upward rotators of the scapula. The lower trapezius and the serratus anterior are the first muscles which have been found to be inhibited, which has been found by Kibler. And this inhibition offsets the enigmatic force couples. If you see the leverage of the muscles of the scapula, the upper trapezius has a higher leverage in the lower movements, whereas the leverages of the middle trapezius, lower trapezius, and the serratus anterior are much more. And that is why they give a higher leverage to the movements of the scapula, and they are very, very important in recruitments. What are the proposed biomechanical mechanisms of scapular kinematic deviations? Inadequate serratus activation leads to lesser scapular upward rotation and posterior tilt. Excess upper trapezius activation leads to greater clavicular elevation. Pectoralis minor tightness will lead to greater scapular internal rotation and anterior tilt. Posterior soft tissue tightness also leads to greater scapular anterior tilt, and increased thoracic kyphosis will lead to increase in the internal rotation, anterior tilt, and lesser scapular upward rotation. So when we spoke about the healthy scapular dynamics, that is upward rotation, posterior tilting, and external rotation, which is very, very important in healthy shoulders, this can happen in unhealthy shoulders. It's a cascade. If scapular dyskinesia is there, it can be the muscles around the scapula are weak. That will lead to also rotator cuff impingement. It will irritate and inflame the rotator cuff and the subacromial space, and it leads to disuse due to the pain at the shoulder, and it's a cascade. What is the alignment impairment model? In any soft tissue tightness can lead to that alteration in that structure, that leads to pathomechanical alteration and leads to impairment. That's one of the important, person, John Bostard, who talks about the pectoralis minor tightness and how he explained about the long and the short head of the pectoralis minor and leads to altered scapular kinematics. Sarman, okay, everybody knows Sarman, okay? She talks about the normal alignment. Normal alignment is extremely, extremely important because if there is no normal alignment, there is no optimal movement. So there is a complex interaction. Scapular dyskinesis, posterior soft tissue tightness, rotator cuff dysfunction, offsets the post couple, leads to anterior superior translation of the humeral head, leads to reduction in the subacromial space, impingement, and therefore shoulder pain. What is the key component? Scapular rehabilitation is a key component of shoulder rehabilitation and should be instituted early in the shoulder rehabilitation. Why scapular kinematics? The volume of the subacromial space during the shoulder elevation is thought to be maximized, thus reducing the incidence of shoulder external or internal impingement. What is the evidence-based view? Therapeutic exercise aimed at stretching the anterior and the posterior shoulder girdle, strengthening the rotator cuff and the scapular stabilizers is recommended over no treatment. There are a lot of EMG-based studies which talks about and which are vital part of creating shoulder muscle balance and constructing an effective exercise program. These advances in EMG studies have found to not even lead to enhancement of the rehab programs and seek facilitation in the recovery while placing minimal strain on the healing structures. So what is a summary of the intervention considerations for the subacromial impingement syndrome? Serratus anterior activation, upper trapezius activation reduction, posterior soft tissue stretching, pectoralis minor stretching, thoracic extension, posture or exercise. What is the rationale? Role of serratus anterior and lower trapezius in dynamic stabilization of the scapula. These force couples are inhibited, and that's why there is asynchrony of the firing of the scapular muscles. This alters the balance between the scapular muscles and thus leads to scapular kinematic alteration. What is the rationale? Higher activity of upper trapezius, which we don't want. There is lower activity of the serratus anterior, higher activation ratios of upper and lower trapezius, and there is delayed activation of the lower trap and serratus anterior. And that is why we need to understand which muscles to recruit and why. We need to decrease the over trapezius activation by taping technologies or by specific exercises, because upper trapezius activation leads to narrowing of the subacromial space. These are the various, this is a taping technology for activating the rotator cuff, lower trapezius. This is how we can activate the serratus anterior punch exercises, and the activation of the serratus anterior will lead to increment in the upward rotation of the scapula, which we need. Balance more than strength. We need balancing of all the trapezii, the upper, middle, and the lower trapezius, also recruiting the serratus anterior. This is the best 5 exercises by Cools et al. And she spoke about the algorithm of how to treat the muscles and how to recruit the right muscles of the scapula. What is the saga of serratus anterior? A fatigued serratus anterior will reduce scapular rotation and protraction, and it will allow the humeral head to translate anteriorly, and that's what we don't want. We need to activate it by push-up plus exercise, serratus anterior, dynamic hugging actions, and these are the exercises which are EMG based, which needs to actually, working on the serratus anterior. Posterior, the rotator cuff activation needs to be done because it has been found that it reduces the subacromial space, it affects the activation of the lower trap and the serratus anterior and the middle trap. And these are the activations of the different angles of the rotator cuff, along with activation of the scapular muscles during the wall exercises. These are the exercises for serratus anterior activation. And what's important, the aim of the rehabilitation is to restore the scapular muscle balance and control. I need to have a balance between the ratios of upper trap, lower trap, upper trap, middle trap, and activation of the serratus anterior. That's the famous Cools algorithm, which talks about whenever there is lack of flexibility, you need to work on stretching. Whenever there is lack of muscle performance, you need to work on control, strength, coordination, strength training, conscious control of the scapular muscles, conscious control of the advanced control of the activities of basic activities or during sports, balance ratios, and work on endurance and strength depending upon the work and the sport. That's again a scapular rehab algorithm which is modified and which talks about even functional training at the end. Ultimately, it's all about not the shoulder or the scapula, but the kinetic chain rehabilitation, because we just don't look at the focused point of the scapula or the shoulder. And that's what we should not do. That's very important that this is the front page of the British Journal of Sports Medicine, which talks about the wrist and shoulder. And we should not be blinded, because when you treat any patients without clinical reasoning, without rationale, without critical understanding of the deductive methods in clinical reasoning, we are not going to treat the patient appropriately. And that's what is very, very important. Thank you. The WCPT slogan is Movement for Health. I would like to reframe it, and I'll say that it's optimizing scapular movement, which is important for glenohumeral health. Thank you.